We
Wait.
have to turn it.
Okay, very good. Okay, fantastic. Well, good evening, everybody. Thank you for joining us. My name is Dr. Nir Lipsman. I'm the chief of the Brain Sciences program here at Sunnybrook, and it really is my distinct pleasure to welcome you to this public forum to serve as a moderator for today's this evening's session. We have a fantastic lineup of speakers that you'll hear from, really representing the latest and greatest in OCD and beyond. So tonight's topic is advances and evolution in the treatment of obsessive compulsive disorder, or OCD. Sunnybrook's program is really driving innovation and treatment in brain health, including mood and anxiety disorders. An integral part of that is our collaborative relationship with the Frederick Thompson Anxiety Disorder Center, directed by Dr. Richter, who's here as well and will be one of our speakers. The Thompson Center is Canada's premier center specializing in OCD and related disorders. It's a center of excellence made up of highly specialized interdisciplinary team dedicated to helping adults from across the country who are impacted by severe and treatment-resistant OCD. So at Sunnybrook, it's our mission to care for these patients and their families when it matters most. It's a part of what makes this place special, as I'm sure many of you know. We recently celebrated, as recently as last week, the inauguration of a brand new brain sciences building, which in the next few months, I hope you have an opportunity to visit. We also care, of course, collectively about our responsibility to achieve reconciliation with Indigenous peoples who have lived on this land for generations upon generations. In that spirit, it's important to note that we gather here at Sunnybrook Health Sciences Center on campuses which are located on the treaty territory of the Mississaugas of the Credit First Nation and ancestral and traditional lands of the Anishinaabe, Haudenosaunee, Ojibwe, Chippewa, and Huron-Wendat nations. Today, this land is home to many First Nations, Inuit, Métis, and urban Indigenous people from across Turtle Island, and we value their contributions past and present and are grateful to be able to work and live in this community and territory. So last week was OCD Awareness Week. It was a worldwide event that serves to dispel myths about OCD, break the stigma around mental illness, and provide education about the disorder and how to support those affected by it. So tonight we are honored to bring together key members of the OCD community here on site at Sunnybrook and those watching online. We're webcasting online to continue that spirit forward. So Dr. Peggy Richter will open our series of talks this evening. Dr. Richter will introduce us to OCD and the wide breadth of treatments that are now emerging. Our second speaker is our special guest tonight from Houston, Dr. Caitlin Pinciotti. Dr. Pinciotti will speak about cognitive behavioral treatment for OCD, how it works, how it evolves when viewed through a justice-based lens. Our third speaker is Dr. Peter Jacoby, who will take us really to the cutting edge of innovative treatment options, and we'll discuss neuromodulation or direct-to-brain interventions for OCD and other conditions. And lastly, we'll hear about one patient's journey receiving OCD care right here at Sunnybrook from Rima Yusuf. So we undoubtedly have an exciting lineup of presentations ahead. I'm sure you will enjoy this evening's talks. And we have set aside time at the end for questions. So you'll see sheets on your chairs. So if you want to write down any questions about anything that you see or hear or anything that comes up, please let us know. We'll collect those papers and we'll save all the Q&A for a panel discussion at the end of this evening where all the speakers will be sitting on the stage and we can ask them questions. For those of you who are online, please feel free to write in your questions into the comment section. We may not be able to get to every question, but we'll do our best to do that in the time that we have available. A few housekeeping notes. Washrooms are located just outside the auditorium. For men's and women's, turn left and you'll exit down the hall. The men's washrooms are on the right. For all gender washrooms, please turn right at the auditorium hallway, right outside the doors, and you'll see them on the right-hand side. Okay, so just to begin this evening, I'd like to introduce our first speaker. Dr. Peggy Richter is a psychiatrist and head of the Frederick W. Thompson Anxiety Disorder Center here at Sunnybrook, which again is a very unique national resource. It's a Canada Center of Excellence for the treatment of OCD and related spectrum disorders. She's also an associate scientist at the Hurwitz Brain Sciences Research Program and at Sunnybrook Research Institute. In addition to that, Dr. Richter is a full professor in the Department of Psychiatry at the University of Toronto. She's an internationally recognized speaker and psychiatrist for her work in the field of OCD. Her research focuses on the genetic and biological basis of the illness and aims to better define the boundaries of OCD and related spectrum disorders to improve treatment outcomes. She's an acclaimed speaker, an in-demand speaker on anxiety, and presents extensively to healthcare professionals and public audiences. So with that, Peggy, I'll hand it over to you.
Hi, everybody. Welcome tonight. Oh, I love this podium. I just have to say, as a relatively height challenged individual, this is a beautiful thing. Anyway, welcome tonight. It's really a pleasure to have you here. Getting echo, is it okay, the sound? Okay, good. And welcome to everybody who's watching online as well. And it's really a delight to be resuming more of these events, trying to do them live again. So for those who made it here in person, we're so delighted to see you as well. Okay, let's see. So this is just for anybody who may want to access any kind of help afterwards. There are resources on the Department of Psychiatry Sunnybrook website, and that's a code for it. Okay, so my topic is rather broad. I'm going to hopefully give you a little introduction to OCD. I think everybody in this audience really knows what we're talking about, but nonetheless, sometimes people aren't sure about all the details. So I'm going to go through that. We'll talk about basics of OCD treatment, what standard of care looks like as of 2024. And then I'm going to try and highlight some of the things I've picked out that I think are more exciting and new that I want people to be aware of. So that's the agenda. Okay, so what is OCD? 3 snapshots, I think, just illustrating what an interesting and heterogeneous or diverse condition OCD can be. All fictionalized versions of people I've seen over the years. Kathy, a 32-year-old lawyer, presented at the time with contamination fears. She was at this point avoiding going out as much as possible because everything around her lived in a world of clean or dirty. And if she was out, she was dirty. And when she came home, she had to be clean before she could touch things. And the problem was to get clean required huge rituals. And she also couldn't deal with belongings in her apartment because if she touched them, chances were they felt dirtier than she was when she was clean and cleaner than she was when she was dirty. So it left her almost impossible situation toward the end where she couldn't even live in her apartment because it just didn't feel suitable anymore. Jamal, an engineer who had retired in his mid-50s, he had such horrendous fears of making mistakes in his work. He was constantly rechecking to the point that he really could not work at all. He had already been downgraded at this point from doing engineering work and was working in the mailroom. But even in the mailroom, a half-time job filled up more than full-time hours because of his checking. And Janice, a stay-at-home mom who had paralyzing fears that she would harm her young children, particularly her infant. And that fear had been so horrible that she was unable to nurse the baby alone, give her a bath, do all those things a new mom would like to do. So these are very, very different pictures, but all are pictures of OCD, which is characterized by the presence of obsessions or unwanted, intrusive or sticky thoughts that the person cannot push away. They can also be images or impulses and provoke considerable anxiety. And in response, most people will have some degree of compulsions, which are repetitive behaviors or mental acts, things that people do to try and make themselves feel better, things such as checking, washing, and other behaviors that might be familiar to everybody. And for us to make a clinical diagnosis, we look for some severity markers. So our typical markers that we would look at in order to say somebody's met that threshold are symptoms causing marked distress, wasting at least an hour or more of their time, or interfering with functioning. And I think these 3 cases illustrate that diversity quite nicely as well. All right. So having said that, while OCD can be about anything and everything, and so it is important to keep that in mind. Sometimes people say, well, this is kind of a weird thought, but it's not typical OCD like I've read about. That doesn't matter because really it's not the content of the thought. It's the experience of it as an intrusive, sticky, unwanted thought. But having said that, the most common themes tend to revolve around people with fears of accidental harm, often checking doors and lights, the car, their emails. Maybe they said something offensive or wrote something offensive. you name it. People with contamination fears, typically worries about dirt and germs. For some, they'll just have identified as a feeling of dirtiness or even disgust, typically triggering a lot of avoidance of contact. Pardon me. When they're out and about, and cleaning and washing rituals. I think where people often are a little less familiar is when we get into just right and symmetry and order. So for folks with symptoms in this domain, it's more about having things maybe lined up in a particular way. It may be symmetry and wanting them even, or it may just be that they have to be precisely the way I like them. It's not that this needs to be lined up perfectly straight. I want it exactly there, right? And it has to feel right. There may be fears that otherwise something bad will happen, things will go wrong, or it just doesn't feel right. And taboo obsessions, I think, are the most, in some ways, the most torturous for people who experience them, because people with this kind of domain of symptoms often fear they're the only ones who've ever had these thoughts, when in fact, pardon me, it's quite a common part of OCD. So people may have violent thoughts or urges or impulses of stabbing their husband, smothering a baby, throwing somebody off a balcony, driving the car the wrong way. They may have disturbing sexual thoughts that go against their orientation and their perspective and that are intensely uncomfortable or distressing for them. Or sacrilegious thoughts that just go against religious beliefs, for example. And again, just to emphasize, I don't mean that people should think of each of these as being in isolation, as most people will have multiple symptoms from multiple domains. So with that in mind, I just wanted to point out OCD is not rare. And this is a rather old slide I pulled together some time ago. He's really just in there because I like the photo. But I got to tell you, I made this slide many years ago. And there was information online that he acknowledged some OCD symptoms. So it's out there. It's ubiquitous. It can affect anybody and everybody from any walk of life. We know that in general, it affects about 1 in 40 people over their lifetime, which actually makes it quite common, more so than most people appreciate. But part of the reason we're here is not just that it's fairly common. OCD is also quite severe. It can range. There are people at the mild end, but unfortunately, some people at the extreme end will be completely disabled and unable to function at all. And OCD can be horrifically overwhelming, such that the World Health Organization has at various times over the last 20 years had it in their top 10 for worldwide causes of disability. And we're comparing it there to things like heart disease, right? Diabetes, stroke. It's also highly comorbid, meaning OCD comes along with its friends. It's rare to have just OCD. Most people affected by OCD will have had episodes of depression. Many, about half, will have other anxiety disorder difficulties, such as panic disorder or social anxiety or excessive worry, known as generalized anxiety disorder. And a fair percentage, somewhere around 20%, may have what we call the OCD-related disorders, problems like hair pulling and skin picking disorder, hoarding disorder, and body dysmorphic disorder, in which people are preoccupied with flaws in their appearance that can become completely disabling to them. And I think the last part of this slide is that beyond that, OCD tends to be quite chronic. So for most people, this is a disorder that does not come and go and get better. It may come and go, but it tends to be there most of the time for most people. So with that in mind, what are the first line treatments? Where do we start? And I assume this is pretty familiar to everybody in this room today. But our first line treatments, meaning those treatments which have the best degree of evidence around safety and effectiveness and being well tolerated, are a specific type of psychotherapy called cognitive behavioral therapy or antidepressants. Thank you so much. That's very kind. Just got something there, so I may continue to do that. So this is our starting point, and I'm going to assume most people are at least a little bit familiar with these. But in brief, Sorry, guys. There we go. When we talk about the medications, our first starting point, our first line drugs are the selective serotonin reuptake inhibitors. So this is a class of antidepressants that work specifically on the serotonin neurotransmitter system in the brain. They're extremely effective, not just for OCD. They were developed first and foremost clearly from their name as antidepressants, and they're used for a broad variety of conditions, also working well across the anxiety disorder spectrum, for example. Beyond that, they're very well tolerated. Mostly side effects are mild and often pass, and they are very safe. And this is a list of all of the major ones out there. There is at least one other newer agent I could have listed there, vortioxetine, sold under the trade name Trintellix, but absolutely no evidence as yet for OCD, whereas all the others on this list do have some degree of evidence for OCD, such that most have a formal indication for it or an acknowledgement by Health Canada that they're effective in OCD, similarly in the US and Europe. So they are our first choice based on that wonderful balance between tolerability and safety and effectiveness. There are a few antidepressants that are in our second line class, and they're there for different reasons. So clomipramine is an older tricyclic antidepressant, as it's termed, based on its chemical structure. It's actually the first agent identified that was uniquely effective for OCD and has been around for wide use since the very late 70s, around 1980. And in fact, when I was early in my training, not that long after that, we would often get Americans driving up for it because it wasn't yet approved in the US, but had been around in Canada for a long time. Very effective, arguably perhaps even a smidgen more effective for more people than the SSRIs, but can be associated with quite a host of side effects that can be far more challenging to tolerate, and in rare individuals may trigger seizures, which is obviously quite an alarming possibility. And so for that reason, despite the excellent efficacy, we consider it a second-line drug, meaning we encourage people to try a few of that first category of SSRI agents first. The other drug we'll specifically name in this category after that are the agents venlafaxine and desvenlafaxine, which are serotonin and norepinephrine reuptake inhibitors. Pardon me. Another class of antidepressants with excellent safety, but in this situation, less evidence. And that's why they're relegated also to being in the second line group. The other class for which we have wonderful evidence in OCD, or at least by OCD standards, wonderful evidence, going to point out that compared to evidence for a lot of other conditions, it's rather small, are the antipsychotic drugs as we typically know them. These are drugs that work on the dopamine neurotransmitter in the brain and were developed initially for people with psychotic difficulties such as schizophrenia and manic depressive illness. But I think that is simply a source of confusion. The important thing is that they work on another important neurotransmitter system, and through that can be very helpful as adjunctive or add-on drugs. These are not drugs that we use on their own in OCD. They don't seem to have that benefit that way, but are combined with one of the antidepressants. And when we do so, can certainly be very helpful for some people. However, they are appropriately further down this list because there are more side effects and certain risks associated with taking them, including longer-term, small but significant risks of developing unwanted movements, for example, known as tardive dyskinesia. So although they're effective, because of those risks, we would also be more cautious about introducing them. And then at the very bottom, I have some drugs in fine print, which we'll come back to, because that's where we're getting into some of the newer options, I'd say. Now, one of the problems with all these treatments is that they're limited in their effectiveness. And that is really a major issue, which is that even when these drugs work, which is about 50% of the time on average, so looking at the first few columns here, we see there we go. The SSRI is working for about 50%, as does venlafaxine. Clomipramine may be marginally higher at 60%. However, even when they do so, the degree of response we see tends to be fairly modest. So these are usually not life-changing, they are life-improving. And remission is not a common outcome. Now, by contrast, our psychological treatments, which I'll be coming back to, and we're going to be hearing a lot more about from Dr. Pinciotti shortly, can work in up to 90% of people and tend to be more helpful. What's the catch then, you might ask? The catch is that unlike medication, which is relatively easy to take, CBT requires a person who is willing to challenge their fears. They have to be able to tolerate fairly significant degrees of anxiety, and they have to be in a place in life where they have the time and the drive to practice regularly. Because like learning any new skill, it takes a lot of practice. And then, unfortunately, a further barrier is access, because in Canada, as I'm sure most of you know, there is very limited availability of CBT from trained practitioners expert in OCD covered by the healthcare system. Most is not, and so finances can be a barrier too. All right, so sorry guys, I'm a few slides remiss about CBT, but that's okay. So what's new? You know, I had to wrestle with thinking about what I would tell you about, but I wanted to highlight that there are a lot of refinements that have come along in the way we can deliver CBT. So I showed you outcomes from classic CBT, and those outcomes aren't shabby. Agreed? You know, if you can do it and you are somebody who's able to do it and has that drive and motivation, you aren't too depressed to practice, they can work really well. But we are nonetheless learning that we can still do better. So among some of the things, I'm not going to speak of much, is justice-based CBT, because we're going to be hearing a whole talk on that shortly from Dr. Pinciotti. And I must tell you, it's a very exciting topic that I think really holds out a promise of doing what we do so much better and so much more respectfully of the diversity in people. So we'll hear about that. In terms of some of these others, I'm going to just highlight a few. So inference-based CBT is something that is getting a lot of publicity in the recent years, I would say, particularly the last 5. It evokes strong responses, but it is a variation in which the focus, rather than being on thoughts about the thoughts, the appraisals of our obsession, like because I had that thought, maybe I want to do it. Maybe I'm a bad or dangerous person. Maybe I want to kill my family members, for example. In inference-based CBT, we focus on the doubts. And the problem there is helping people to realize that they're drawing conclusions based a lot on imagination and as well by not trusting their own senses. And so we work with them at that level to begin to recognize the faulty reasoning process. There are also things, there was some animation. So let me come back to some of these others. Traditionally, we would think of CBT, or exposure and response prevention, which is the behavioral part of CBT, the B, as based on exposure and response prevention, meaning expose yourself to a trigger of your obsessions and stay with it and don't ritualize. And when people do so, classically, what we see is a graph of their anxiety over time, showing a rather sudden peak in anxiety, a bit of a plateau, and then gradually coming down. And the accepted wisdom based on the last 70 or 80 years or longer is that with practice, we see this habituation, this improvement within sessions and between sessions, such that by maybe the 20th practice, people's anxiety is not going up nearly as high and comes down faster. The problem is this model doesn't apply to everybody, and that's where room for these refinements has come along. Classically, I should mention, this is done using a hierarchy or a fear ladder, a list of triggering situations, and people would work up fairly gradually from easy to hard. So what we have learned more recently in the last 10 to 15 years now, a lot of this work is by Michal Krasky, a very important figure in this area, is that we don't actually extinguish fear learning. We can't erase it. What we can do is master safety learning. And by practicing that a lot, our brain will eventually realize this thing is not as dangerous as we thought. And what that means is that anxiety doesn't have to decline during exposures. We do have to be willing to tolerate it. There's also a type of therapy called acceptance and commitment therapy, which focuses, this was, an example of inhibitory learning where we might also want to combine numerous fear cues at once. So this says Professor Gallagher and his controversial technique of simultaneously confronting the fear of heights, snakes, and the dark, all in one. Not a party for most of us, right? Okay. Now, acceptance and commitment therapy has a number of other perspectives, one of the most important of which is focusing on doing what aligns with our values. OCD does not, right? It keeps us from doing those things that we care about most, being with family, friends, other activities in our lives. So when we incorporate ACT, we are using a values-based approach, and for many people, that can really improve outcomes. Inferential CBT, I think I've already spoken to, so I'm going to skip that. And then there have also been some developments in terms of changing the intensity of treatment. The Bergen program is not available in Canada. It's an interesting program developed in Europe that actually gives people a very intensive experience over 4 days and 4 nights, and does seem to be effective. But what we do have here, and we're so delighted and proud to be able to offer it at Sunnybrook since 2017, is Canada's only intensive program for delivery of really intensive CBT, where rather than meeting with a therapist once a week, we're with them 5 days a week and on weekends. And what we find is that that can help people even with really severe OCD, as demonstrated here by improvements in scores. And I would be remiss not to remember Dr. Marlene Tope-Schiff, who now is in private practice, but really helped us in setting up the program and did a lot of that heavy lifting in the early years. There are a lot of medications under investigation. I'm not really going to speak to them, other than perhaps very briefly to one called troriluzole, which is rather interesting because it's related to a medication that we already know to be effective for OCD, but very difficult to tolerate. And this one is currently under investigation. If you're interested, there is material about it outside on one of the tables. And this is another area where there's been a ton of interest. So I just liked some of these photos, but psychedelics have gotten a lot of attention in recent years as they come back into favor. We recognize that they were thrown out way too early, and they can be really helpful and are being used increasingly with post-traumatic stress disorder, severe depression, depression and difficulties related to having fatal conditions such as cancer. And in OCD, the excitement has really been around magic mushrooms, psilocybin, which offers some promise. A word of caution. I'm sure many of you have read about it online. People talk about this as the best next thing since anything. The total evidence out there is one study of 9 people over 4 weeks. Other than that, we have anecdotal evidence, which is our lowest level of evidence, because we know people are going to be more biased to report it when they do well than when it didn't work. So there's a lot of interest and excitement. I think it's very early days. And last, I'm just highlighting one of our next speakers. Dr. Jacoby is going to be telling you a lot more about biological treatments that can actually alter brain activity through neuromodulation. So I'm not going to speak about them, but just flag them with more to come. And on that note, I want to end by saying there are effective gold standard treatments for OCD. Not always beneficial to everybody by a long shot, unfortunately. We always want to be considering CBT. And when CBT even intensively doesn't work, we want to think about some of these newer treatment options. And on that note, I'm going to stop. Thank you.
Thanks very much, Dr. Richter. And is it me or did the podium decrease on size? Okay. Is there a button? Okay. Sorry.
Yeah,
Passive aggressive there. Okay. The mushrooms, exactly. Hallucinating. Okay. Well, thank you, Thank you, Peggy. I think it just underscores, first of all, I'll just mention that again, questions we'll take at the end. So please, you may have many questions, write them down. We'll have a panel at the end. We can ask those questions, but just underscores how fortunate we are to have Dr. Richter and her expertise in the Thompson Center here at Sunnybrook, really a world-class expertise and facility. Thank you very much. I'd like to introduce our next speaker. Dr. Caitlin Pinciotti is a licensed psychologist and assistant professor in the Menninger Department of Psychiatry and Behavioral Science at Baylor in Houston. She received her PhD in clinical psychology with a trauma psychology focus at Northern Illinois University and completed her predoctoral residency and postdoctoral fellowship at Rogers Behavioral Health in the OCD and anxiety track. Dr. Pinciotti has treated individuals with OCD and PTSD at all levels of care, ranging from community and Veterans Administration outpatient clinics to residential treatments as well. Dr. Pinciotti's research focuses on the assessment, conceptualization, and treatment of OCD, trauma, and PTSD, in particular when these conditions and experiences intersect. She has given more than 40 conference presentations and published more than 50 peer-reviewed journal articles and book chapters on these subjects. We're so happy to have her here. Thank you so much for joining us and sharing your expertise on justice-based CBT for OCD. Without further ado, please welcome Dr. Pinciotti to the right here, and you can go up or down. Okay, very good. Okay, thank you.
Yeah, thank you. All right, I'm just gonna move this right back down. So, thank you for having me. I was really honored to be asked to join you all this evening and be able to see your state-of-the-art facilities and especially this state-of-the-art podium, which is a great idea because I usually, as you were just saying to me, have to sort of be on my tippy toes. So this is very inclusive. So I appreciate that. So I'm Caitlin Pinciotti. I'm going to be talking about justice-based CBT and how we can apply this approach to identity-related OCD themes. So I want to just start by talking more specifically about what I mean when I say identity-related OCD. So as Dr. Richter described so well, OCD can encompass any kind of number of different themes, really sort of virtually limitless. And we believe that all of these themes, what they have in common is this kind of underlying intolerance of uncertainty and core fears. So you have sort of like the surface level fear, whether it's contamination or harm or scrupulosity, but underneath that are these sorts of characteristics that there's sort of a deeper core fear that someone might have and this extreme intolerance to uncertainty. And so one of the themes kind of goes by lots of different terms, but we call it taboo, unacceptable thoughts, repugnant thoughts. These are fears or doubts related to identity, impulses, sacrilegious or immoral behaviors, etc. And we know that about 43% of people will endorse some of these obsessions. So more specifically, as it relates to this topic, people can have fears or doubts that are centered on identities or characteristics that are marginalized. So when we say identity-related OCD, it's some sort of fear or doubt about having or potentially developing an identity. So I kind of, when I try to think about like what are all sort of the range of ways that people experience identity-related OCD, it's typically some sort of fear or doubt of being, becoming, being perceived as, being unsure about, or being punished for being some sort of identity. And what we find is that these fears and doubts are often linked to stereotypes about those identities, a concern for being mistreated if one were to have or develop an identity, and then catastrophic beliefs about the causes or the consequences of holding these identities. And so when we think about how we sort of define OCD, we think that, obsessions are obviously unwanted and intrusive. And so they're sort of like predicated on this assumption that there's something bad or that could be bad associated with the obsession if it were true or if it were to happen. And so what I've argued for is that the existence of identity-related OCD is really predicated on society deeming certain identities unwanted or undesirable in the first place. So this may not necessarily mean, and often does not mean, that the person themselves, holds these biases, that they're, homophobic or transphobic or racist or whatever it might be, but rather that these messages are internalized for all of us. And so oftentimes these people will say, I don't have anything against gay people. I just really feel uncertain about my identity, and I feel like I can't move forward until I figure out who I am. And so I use this example sometimes about like eye color to sort of to illustrate this a little bit. That you would be, and I'm not going to discount, and of course anything with OCD is possible, but you would be less likely to see someone present with obsessions or doubts about their eye color. Like, I have green eyes. What if tomorrow I wake up and all of a sudden my eyes are brown, right? Again, anything is possible, but there wouldn't be any sort of like social consequence to suddenly having brown eyes versus having green eyes. Whereas there are social consequences to holding marginalized identities, whether or not you yourself ascribe to some of those beliefs. So this is really kind of a culturally bound presentation of OCD, holding a sort of like undesirable identity in a hostile society would, of course, cause distress for anyone, regardless of how you personally felt about that group of people. An example of this being that, there are some cultures who revere gender diversity. Here I have an illustration of folks who identify as like two-spirit within Indigenous cultures. Those cultures that really believe that gender diversity is sort of like this spiritual or this like really wonderful aspect of identity would probably be unlikely to have a lot of gender identity related obsessions, because it would be seen as sort of a good thing, or at the very least sort of a neutral thing compared to, unfortunately, what we see in a lot of Western cultures. So this is by no means intended to be kind of an all-inclusive list, but just to give you a sense for different identities that can be marginalized and how OCD can latch onto those in different ways. So if we think about race and ethnicity, what we often see, or what we might call like racism-themed OCD, often manifests as a fear of being or being perceived as racist, or a fear of blurting racial slurs. So I'm afraid that I'm going to sort of lose control and blurt out this really horrible word in front of someone. Related to aging, this can be kind of a fear that one would be contaminated by older adults. Oftentimes this can be in the form of like an essence contamination, like I'm fearful that I might become contaminated with a characteristic of older adults that I don't want to have, again, often sort of rooted in stereotypes about older adults. Or a fear of developing different mental or physical changes that might come along with aging, for example, dementia. Related to disability and diagnostic status, again, we can see a lot of this with sort of an intersection with contamination. So a fear of being contaminated by some sort of disease or disorder. If you have a fear of, let's say, losing your vision, then it would probably be very anxiety provoking to be around someone who actually did have that struggle. And if you felt like you might sort of catch that from them. Or what we hear a lot is folks saying like a fear of going crazy. Generally that means like having like a psychotic episode. In terms of socioeconomic status, you might see folks feeling, again, kind of a sense of like contamination associated with being around unhoused people, or maybe a fear of themselves becoming poor, unhoused, or financially unstable. In terms of gender identity and expression, fear of becoming, or being perceived as a different gender, or what we see, I think, most commonly is just sort of a fear of not knowing. So again, going back to that folks often don't necessarily ascribe to these stereotypes or these negative beliefs about groups, but I don't feel like I can proceed in my life if I don't know what my gender is. I feel like I'm being dishonest to people and dishonest to myself. And sexual orientation kind of manifests in a similar way as gender identity. So again, that fear of being, becoming, or being perceived as a different sexual orientation, or a fear of never knowing. So now let's talk a little bit about what CBT for identity-related OCD.
Your attention, please. Code white. F Foxtrot, second floor, room 58. Your attention, please. Code white. F Wing Foxtrot, 2, room 58.
Does anybody need to? We're good. Okay. So Dr. Richter did a really great job of covering CBT. So just as a reminder, CBT, this is kind of the CBT triangle. And you can see that there are arrows that are moving in both directions, which means that we think that all of these things are kind of constantly interacting with one another. So when we think a certain way, that influences our behaviors, but when we behave a certain way, that influences our thoughts. Similarly, when we're feeling certain emotions, that's going to influence how we behave, but also if we behave in different ways, that can influence our emotions, and so on and so forth. And so all CBT treatments that fall under this umbrella of CBT that Dr. Richter described are kind of rooted in this belief. And namely, exposure and response prevention is kind of the big B piece. So the idea that how can we help folks change their behaviors to then have this impact on their thoughts and their emotions, with the emotion primarily being anxiety. And so exposure and response prevention, or ERP, why do we think ERP works? We believe that people have these sort of pathological if-then beliefs. If I do this, then this horrible thing will happen. If I don't do this, then this horrible thing will happen. Typically being, if I don't engage in my compulsions, then some sort of catastrophic fear will become true. And so folks then understandably avoid situations where they feel anxious, where these obsessions are triggered, or where their fear could potentially come true. And then that just sort of maintains the anxiety and the fear because there isn't this opportunity to challenge that fear and see what actually happens. And so these sort of I can't beliefs grow, and OCD, like other anxiety disorders and post-traumatic stress disorder, gets bigger and bigger and bigger while people's lives get smaller and smaller and smaller. So how do we implement ERP? First, we would identify these situations that are feared or avoided. And just like Dr. Richter described, we develop an individualized hierarchy or a fear ladder that sort of goes through all of these different situations, and we might rate, how anxiety provoking they are, and then repeatedly approach these situations while also resisting compulsions. So that's the response prevention piece. It's not enough to simply expose oneself to something. A lot of people will start treatment saying, like, I expose myself all the time. I'm constantly anxious. I'm constantly being exposed to my obsessions. But there isn't that response prevention piece, and that's why they're not seeing any relief from their symptoms. And so the main kind of tenets of ERP are habituation, which I have an asterisk here because of inhibitory learning, which I'll speak on that in a moment. Having corrective experiences and developing self-efficacy. So habituation being this, metaphor that we often use is like if you jump into a really cold pool and at first your body feels freezing and you might feel like, I can't tolerate this, I have to get out of this pool right away. But if we stay in the pool long enough, we find that our body just naturally comes back down to normal. As we sort of in biology, if you remember the term homeostasis, like our drive to sort of like return to a baseline state. It's believed that anxiety works in that way too, that if you allow yourself to fully experience anxiety without trying to push it away, it will naturally come down over time. Both in terms of the within and between session habituation that Dr. Richter described. This model has been challenged a little bit more in recent years, with folks saying habituation isn't necessary, that really the biggest, most effective part of ERP is just allowing people to have a corrective learning experience. I thought if I didn't do my compulsion, that I would get really sick, but I didn't. And I'm sort of learning something new associated with my behaviors. And then this piece of really developing self-efficacy. So reducing those I can't beliefs and really kind of challenging and showing somebody that they're much more competent to do the things that they've been avoiding than they might feel like they have been. And so justice-based ERP was sort of developed out of this observation that as a field, our approach to ERP has become a little bit misaligned. Not that there's something inherently wrong with ERP, but we've sort of veered off course a little bit. What you might hear people say, or what I've heard people say, is that the content of obsessions is totally irrelevant. You just do ERP the same way for everyone, and it doesn't matter. And I understand the intention behind that statement is that ERP can be effective for all presentations of OCD symptoms. But I wouldn't go so far as to say that the content is irrelevant. What ends up happening when we have that perspective is that we target these obsessions and compulsions, regardless of whether there's some sort of inaccurate or distorted belief that's underlying it. And so there can be, in this misalignment, an overemphasis on the surface level fears by way of what we might say overcorrection exposures. So I worked with someone once who had gender identity related obsessions. But it's sort of catastrophized as like, if it turns out that I'm trans, then that means I have to become a sex worker. And if I just sort of took that at a surface level fear, I'd say, okay, well, we're going to do a bunch of exposures about you being a sex worker. But here you can see there's a place where we can try and address that stereotype and that sort of misguided way of thinking. But when we only focus on surface level fears and we do these sorts of overcorrections, which is doing something to the extreme, then we really kind of lose that focus on the core fears and the intolerance of uncertainty that's really underlying ERP, or underlying OCD, I should say, and really what ERP is intended to target. So the issue with doing overcorrection exposures, and just as an example for folks who maybe haven't heard this term before, a really simple one would be like if I had contamination fears and I just like took my shoe off and decided to like lick the bottom of it. You might say like, well, what's the function of that? Or like, did you actually need to do that? And I would say that there's probably a larger conversation that maybe can be had in the field of OCD broadly about that. But as it specifically relates to identity-related OCD in particular is where we've really sort of focused this dialogue for now. We've seen that a lot of times people will describe, because OCD is so has such a chronic course, that their surface level fears sort of jump. Like, well, when I was a child, I had just right OCD, and then I started having scrupulosity, and now I have harm. And it sort of bounces around, and it's like a little bit of a game of whack-a-mole. I would argue that in at least some of these cases, the reason for that is that there may be some sort of shared underlying core fear that hasn't been adequately addressed. So I've worked with people who maybe reassured themselves out of their sexual orientation obsessions, but now they have an obsession about something else, and there's kind of a core fear that's underlying, that's linking both of those things that wasn't addressed. I always use this term, this is a colleague of mine, Marty Franklin, has used this term fear factor approach. If you guys remember that show where, you know, they'd have people do these really, really extreme things. And so we might call these overcorrection exposures like a fear factor approach, really kind of high shock value, but low association with the person's actual values or where they need to be functioning in their life. And so there's sort of this prioritization of like, what's the most anxiety that I can get out of this exposure without actually considering what is actually going to help this person in their life. And so when we use overcorrection exposures for identity-related OCD, we risk reinforcing stereotypes, like this case of associating transgender identities with sex work. And it can be burdensome on the provider and others. And so going back to that statement of like the content of OCD is irrelevant, we really need to apply ERP thoughtfully when we're treating identity-related OCD themes. And so really quality ERP must do the following. It really must consider the context that the exposure is being done in. An example of this outside of identity-related OCD is, let's say if somebody has harm OCD and they're really avoidant of knives. Many of us in this room have probably participated in an exposure where somebody held a knife up to you. And that was the exposure that they chose to do to help them sort of challenge this fear that they would lose control and stab their therapist, which is a great exposure. But we wouldn't have someone do that exposure to someone who had a trauma history. Let's say that somebody was actually attacked at knife point. That context matters. We have to consider who might be impacted, both in our immediate space and then as well as a society. And then considering our ethical responsibility. So I pulled, these are from the psychologist ethics. I won't go through each of these, but I thought some of this language was kind of helpful to think about the ethics that we have and how we're really called on as professionals to not only work in the service of the person that's immediately in front of us, but also consider the impact of our work on society as a whole. And so, so this leads me to justice-based ERP. So this was a paper that I led that was published in Behavior Therapy back in 2022, where we applied and first introduced this idea of using a justice-based lens for identity-related OCD, specifically as it related to sexual orientation and gender themes. I've since published a follow-up paper that expands this further to some of those other identities that I talked about on a previous slide. But for the purpose of sort of keeping this focused and going really in depth about what this can look like, these next few slides will focus on sexual orientation and gender identity. So first, a definition. So in this paper, we defined justice-based treatment as an equitable, thorough, and compassionate lens through which to conceptualize and implement mental health treatment so that all impacted persons, client, provider, and society are respected. So these are some kind of fundamentals of justice-based ERP. First and foremost, considering the language that we're using, I've actually seen most people move away from this language, but I still hear this every so often, and so it's still worth kind of keeping on these slides, that people will sometimes refer to HOCD or homosexual OCD. We now call it sexual orientation OCD for a number of reasons. One of them being that homosexual doesn't encompass all of the possible sexual orientation identities that OCD can latch onto. People can have obsessions or doubts about being bisexual or doubts about being straight. And so it's not really the most accurate term. And the term homosexual is a little bit pejorative at this point. And so calling this SO-OCD is sort of where we've moved as a field. Earlier, I used this language, kind of repugnant and unacceptable taboo thoughts. Where we're at right now with the research that we have, although I'm working on this and I'll share a little bit about this, is we don't really know where to lump these identity-related themes. And so what we've done effectively is lump sexual orientation and gender identity themes, for example, into the same category that has pedophilia and bestiality and murder. And we probably all could agree that there's probably some differences in that, and those things are not comparable in any way. But we just have lacked the research to really look at these themes more specifically and figure out where do they lump together. Maybe there's a whole other kind of construct that these should lump together. And I'm collecting data on this right now to be able to answer that question. And I'll, not to do a teaser, but I'll be talking more about this research this weekend at the IOCDF conference. In terms of conceptualization, this involves identifying the historical and the systemic roots of the obsessional theme. So What is the context in which this person has developed this obsession? This can be helpful both for as a provider, if you maybe have kind of a knee-jerk reaction of feeling like, oh, I feel really offended by what this person is saying, helping to really understand where this comes from, where this messaging was learned, but also helping the client to externalize those biases onto the society that taught them. What we see a lot, because again, these folks most of the time don't feel negatively towards these marginalized groups. So they feel a lot of shame. Like, I don't want someone to think I'm homophobic. I'm really not homophobic. I just have these doubts about my identity. And so doing some psychoeducation around this piece can help sort of draw that comparison and help people understand it's not you. These are the messages that society taught you. And then, of course, the main component is doing exposures related to uncertainty and core fears, neutral and positive stimuli, and psychoeducation. And I'll talk about all of these specifically. So the big one, uncertainty and core fears, the function of this, targeting the root of the problem. Somebody might not have an issue with being trans or being gay or being bi. There's something underneath that. So we can do what we call sort of like a downward arrow approach, where we sort of help the person dig, like, okay, I hear that would be really distressing, but why do you think that's so distressing for you? And you can kind of like dig a little bit deeper with folks to get at, for example, someone might feel like the core fears, I've been living an inauthentic life. I've been lying to myself. I've been lying to other people. It's not really about being trans. It's that I've been lying to people, and the trans identity is sort of just a manifestation of that. So then we can do exposures to those core fears, both specifically related to the theme, but then also more broadly, while also working to tolerate uncertainty. So some examples, if someone has this core fear of living an inauthentic life, maybe let's do some exposures around other times that the client was dishonest. I imagine that person would feel really anxious doing exposures to those. If the fear is that they would be stigmatized, perhaps there's other times in the client's life where they felt ostracized. Maybe they feel such an aversion to being ostracized because they were bullied when they were in school, and they still remember that feeling and now want to avoid that at all costs. In terms of uncertainty, a lot of times, again, there's this piece of like, I don't know how my life can move on. I need to have certainty in order to proceed. And so we can do exposures around what might future events look like if you never gain that certainty. So maybe you miss out on having a wedding because you can't figure out, quote unquote, what your identity is. Or we could potentially do things like leaning into the fluidity and arbitrariness of labels. So OCD, like people, really likes kind of neat categories. Like if I can keep something in a category, it makes it really easy to avoid it, right? But if we can talk about identity, certain aspects of identity being more on a spectrum, then that sort of throws OCD off a little bit, because we're like taking away some of that certainty that it felt like it had. Neutral and positive exposures allow us to target those surface level content without harming that community. So of course we need to actually address those pieces, especially if folks are avoiding being around groups of people. So some neutral examples where we can target that surface level fear would be kind of neutral stimuli like pride flags or writing a coming out letter, talking to someone of the same gender, and tolerating the uncertainty that that person might think that you were talking to them because you found them attractive. Positive examples that I have, if appropriate, because if this would kind of reinforce somebody's OCD and feel like it gave them the reassurance, then we wouldn't want to do these sorts of things. But there can be exposures around promoting positive attitudes about the LGBTQIA+ community. An example being maybe writing an imaginal script where someone kind of imagines that they do actually get certainty and they find out that they are LGBT and they're actually much happier that way. For those of us who've treated this presentation, again, we can think about folks we've worked with who that would still be very anxiety provoking. It wouldn't be like, oh, okay, well, if I'd be happier, then I'm good. It'd still be like, well, but what about my spouse? And what about my kids? And what about this? So we can still have them address this piece without catastrophizing, like your life would be over if it turned out that this was true about you. Psychoeducation allows us to sort of two things, an opportunity for exposure, which is always good, but also an opportunity for corrective information when that's needed. And so in this example that I gave earlier about all transgender people being sex workers, that's a really good avenue for doing psychoeducation about that. And there are ways that that person could do exposures where they learn about, maybe the history of transgender individuals or the history of sex work or whatever it might be, and they're educating themselves and still having these opportunities for exposure work. These can look like doing exposures around how identity develops and how it can be fluid over the course of time, different aspects of identity. So again, OCD wants like kind of really neat and clean categories, but there are lots of different ways that we can break down even sexual orientation in terms of sexual attraction and romantic attraction and things like that. We can do exposures around the historical context of groups, prevalence statistics, processing themes that are specific to the client. So if there's obsessions around gender identity, maybe processing some themes around kind of thinking of masculinity as on a spectrum and femininity as on a spectrum separate, and thinking like, how masculine do you feel like you sort of present your clothes and your, perhaps behaviors and things like that. Again, taking out these sort of neat categories that OCD wants us to have and leaning into sort of the arbitrariness of some of these things. So these are just some kind of points for reflection. And this is, as I said, this is specific to sexual orientation and gender identity OCD, but we can take that out and plug in any other sort of identity, and these questions would still be relevant. So does this exposure tokenize or out an LGBT person? Does it reinforce stereotypes or add minority stress? Does it ignore historical trauma for LGBT people? Is there a different way that we could make this exposure and achieve the same result? Is there a way that we can make the exposure about appreciating or celebrating rather than just simply tolerating a community? This is a big one. I previously worked at Rogers Behavioral Health, where we were in a milieu setting, and so patients were around when everybody was doing their exposures. Would this exposure need to be clarified to peers or others? So that would come up sometimes, that if it felt like I really should pull this person aside and say like, hey, what that person is doing is just an exposure, like don't feel offended by it. That's a good time to sort of check your gut, like, okay, maybe we don't need to do that exposure then if I feel like I need to clarify it to someone else to not hurt their feelings. Is the patient's distress rooted in cis or heterosexism? And then the big one, and I have this bolded, would you feel comfortable doing this exposure in front of an LGBT person? Because I think this is the big one where we can check ourselves. If we have that hesitation, and again, this could be LGBT, this could be a person of color, this could be an older adult, whatever it is, if it feels like we would feel uncomfortable doing this exposure in front of that person, then it's probably not an exposure we need to be doing. An example of this, someone came to me once and said they were working somewhere in also kind of a milieu setting, where there was a patient who had racism obsessions, and specifically around a fear of blurting a racial slur. And so they had this person writing the racial slur on the whiteboard in a room. And they simply told the Black therapists not to go into that room while this exposure was happening. And while I appreciate that thoughtfulness, again, that's where we can really sort of like count on our gut to be like, okay, if we need to start protecting people from the treatment we're doing, then let's think about our ethics and let's think about what we're really doing and how can we achieve this in a different way. And so this would be like an example of a justice-based hierarchy. This isn't real, this is fictional, so these ratings are just a way to sort of illustrate how someone might kind of rate from 0 to 10 how anxious each of these would make them. But holding a pride flag, tolerating uncertainty that a stranger might be LGBTQ. This is a big one. I've heard examples in the opposite direction where someone's told to sort of find someone who looks quote unquote like they're LGBT and go and talk to them. Not only does that reinforce stereotypes about what people look like, But again, it's sort of fueling the OCD because it's telling the person, like, you can tell, and therefore it's easier to avoid those people. Whereas the reality is you don't necessarily know what someone's identity is. And so is it not a more potent exposure to have that mindset of literally anyone I interact with could have this identity? Attend an LGBT event where allies are welcome. Read about the difference between identity and expression. Watch LGBT content that's created by LGBT creators. Describe the harmful impact of slurs to someone else. Compliment someone of the same gender. Educate someone about history. Come out to someone who responds neutrally or positively. And then writing a worry script about leaving one's partner for an LGBT person. I don't think I included it in my slides, but in our call to action paper, we have in the appendix 2 different sorts of worry scripts, one of them being kind of an overcorrection worry script, and one of them being justice-based, to give an example of how we can still evoke anxiety, but without harming. And so some final thoughts. Justice-based ERP is ERP. I'm not advocating for throwing ERP out and replacing it with something totally different. In fact, what I'm advocating for is coming back to the home of where ERP came from, those central tenets that have made ERP so effective, really emphasizing those core strategies. Justice-based ERP is better aligned with our patients' values and their needs, as well as our ethical principles. And it may improve buy-in among our clients. This is, again, some data that I'll be presenting this weekend in a little bit more depth. But we know that there's also a lot of stereotypes out in popular media about what exposure therapy is. And it's in large part because of these sorts of overcorrection approaches. And this is my information. If anyone wants kind of updates about the research that I do, I'm still holding out on Twitter. I don't really know why. I think I'm a glutton for punishment. It's not super functional anymore, but I do tweet about my research, and then these are some other ways to access that work. So thank you.
Thank you so much, Dr. Pincioli. I just want to thank you for the talk and also the work that you do, and just comment how far we've come as a field, as a specialty, to have those important conversations. So thank you for all the pioneering work you're doing in this area. So as a reminder again to our audience, please save your questions to the end, write them down, and we'll get to them at the panel discussion. So our next speaker is Dr. Peter Jacoby. Dr. Jacoby is the clinical lead of the Hartwell Center for Neuromodulation and a psychiatrist in the Department of Psychiatry here at Sunnybrook. He's an associate professor in the Department of Psychiatry at the University of Toronto with an appointment to the Division of Brain and Therapeutics and the Division of Geriatric Psychiatry. His clinical interests are in the area of interventional psychiatry, which we'll hear all about in the next 15 minutes. He's one of the very few psychiatrists in the world, actually, with expertise across many different kind of modalities that span the spectrum of invasiveness, as you'll see, from deep brain stimulation to focused ultrasound to RTMS. So really a privilege to have him at Sunnybrook, and for having him join us this evening. Thank you.
Okay, thanks very much for the introduction, and thank you everyone for deciding to spend the evening with us. I'll be talking about OCD, but from a different lens, more of a brain circuitry intervention lens, with the understanding that thoughts and emotions, as we heard from the 2 previous talks, are manifestations of brain activity. So with that, I put together this talk which has the title of Magnets, Sonic Waves, and Implants. What can we do from a neuromodulation perspective to treat OCD? Here are my disclosures. All my slides are my own, although we have received in our center funding support for the work that we've done. So I think in terms of the field, we're undergoing a change in the conceptualization of psychiatric conditions as being conditions of brain circuitry. So, or circuitopathies, not dissimilar to Parkinson's or other brain conditions where we have aberrant activity in loops that's hard to modulate. I like to think of OCD as a non-OCD specialist as kind of like an emotional tremor. It's hard to turn off some of those thoughts or impulses, and what can we do that can borrow from the therapeutics of other neurosciences to apply to these conditions. And here we have actually two leaders in the field, Thomas Insel, who's the previous head of the National Institute of Mental Health, who championed this approach almost a decade plus ago, where he said that the phenomenology approach, where we identify symptoms and then use that as our metric to assess mental conditions, is not adequate. But rather, we should go deeper and look at biological processes that cut across all of these different conditions. So with that, he championed what was called the RDoC approach, looking at circuitry-based conditions and across the spectrum. His successor, Josh Gordon, really doubled down on this, and they actually said that, you know, not only did he buy into this vision, but he was thinking about the future of psychiatry as being circuitry-based psychiatry. So we won't have OCD specialists, but we'll have hippocampal dysfunction specialists. We won't have mood disorder specialists, but we'll have dorsolateral prefrontal hypoactivity specialists. So it's a very provocative vision, but we'll see to what extent we can apply that. This concept has actually really been you know, more and more popular in the lay press and in the public. So these are a couple of books that have come out recently with this idea of electricity and the brain as an electrochemical organ. So there's this book here by Timothy Jorgensen, which talks about the life of electricity and the electricity of life. And then a more recent one called We Are Electric. So I think most people have heard about the genome and the connectome and maybe the microbiome, but maybe we have to get ready for the electrome here. So we're, you know, in terms of how our body interacts and is affected by external energy forces. There's now growing interest in this area of circuitry-based therapeutics due to a lot of converging different angles here. One is, again, the recognition that the brain is an electrochemical organ. If we were giving a cardiology talk, we'd be talking about lifestyle modifications for heart health, medications, maybe pacemakers, maybe cardioversion. I don't think this is a stretch to say that we can apply a similar framework to psychiatric conditions, looking at how we can interweave both medications, lifestyle choices, and brain stimulation. We have to do this because, as Dr. Richter mentioned, a significant percentage of people don't fully respond to medications and CBT, and we need to look to help those people. We now know more about the brain than ever before, but it's not complete. So the models we have are further ahead than before, and they give us some clues as to where we can intervene, but by no means is the story completely written, and we have to do a lot more in this area. But now we have multiple technologies which we can then use to activate and inhibit certain parts of the brain to therapeutic effect. So the objectives in the next 10 minutes or so is to just do a quick overview of physiological principles of brain stimulation as applied to treatment. How can we take what we've learned about the brain and from the bench and apply it to the bedside? And then also to increase your knowledge of the rational evidence for two different approaches, both magnetic stimulation with TMS and neurosurgical approaches with deep brain stimulation and focused ultrasound for the treatment of the most resistant cases of OCD. Here's a quick picture of transcranial magnetic stimulation. Just a quick show of hands. Have people heard of this approach? Okay, this is great because I think 5 years ago there were a few people. So I think this is becoming a more recognized approach. What this approach capitalizes on is the fact that magnetic fields can penetrate solid objects with little resistance. So this is magnetic fields that are being used to stimulate, in this case, the dorsolateral prefrontal cortex. And it's going through the scalp and the skull to stimulate that area. This is not dissimilar to an ambulatory procedure like going to the dentist. And so you sit in the chair, there's no anesthetic involved, there's no seizure. And after the session, which can be anywhere from 3 to 20 minutes, people then go home and come back the next day. And typically we offer these treatments 5 days a week for 4 to 6 weeks. So again, how can we use these principles of magnetic stimulation therapeutically? We know that magnetic stimulation, because of its precision, allows us to control the location and extent of stimulation to a greater degree than applying electricity externally to the brain. And here you can see that when you give high frequency stimulation which is 10 hertz, so 10 pulses per second or more, that activates the brain cells underneath. So that area increases in activity as highlighted in red here. When you give low frequency stimulation, what it does is hyperpolarize the cell or make it less likely to fire. So that part of the circuit is decreasing activity. You can see here that there's almost unlimited parameters. We can put in different spots in the brain, use different excitatory or inhibitory parameters. So there's a lot of potential uses for this, but there are 3 approved uses, including OCD, which is one of the approved uses by Health Canada and the Food and Drug Administration. How effective is TMS for OCD? So again, there's many different options that different spots that have been looked at and parameters. There is a key missing word here. Active stimulation has been found to be superior to sham. That one we're missing, which is an interesting omission. But in the cut and paste, that one missing. But it's found to be as superior to sham stimulation. What we can do with TMS is actually personalize the stimulation to the person's physiology. So we put the coil over the motor cortex to elicit an involuntary motor response on the opposite side. The way our body is set up is that the left side of the brain controls the right side of the body. So we put a single pulse on the spot here, and it causes a twitch. When we know that we have the minimum energy to do that, then we know that that is the amount of energy to activate that person's nervous system. So unlike medications where everyone starts off at 10 milligrams, then go to 20 or 30, we can start off right away with a personalized dose for that individual. Then we typically move it forward to the DLPFC, which is about 5 to 6 centimeters forward, to stimulate that part of the brain, which plays a role in both emotional regulation, depression, as well as executive function. And we are about to begin a study, with Dr. Richter looking at this form of TMS for OCD. There are some limitations to this treatment. It's not widely accessible. Not every center has it. It does require people typically to come in every day for 4 to 6 weeks, which can be a big exposure therapy by itself for people with OCD to come in to receive treatment. And even throughout COVID, we're offering this treatment. I was very impressed by people's bravery to come in and receive the treatment during that time. There's no consensus on the optimal TMS parameters, but there are many different studies that have shown different parts of the circuit when activated can lead to therapeutic effect. What are the side effects associated with this? So because we're stimulating the scalp will contract while the procedure is happening. It's kind of like a TENS machine, if everyone has experienced one of those. And then when you turn off the stimulation, it goes away. But during the stimulation, people can experience scalp pain, can have a headache afterwards, which can be treated by over-the-counter analgesia. Seizure induction is the most severe side effect. Thankfully, we've not seen that in the 5+ years that we've been doing TMS and treating hundreds of people. Mostly people who are at risk of having a seizure are people who have a personal history of seizures or on drugs of abuse or other risk factors. So if you have a history of seizures, it probably is a red light for you, or any metal in your head or neck. So dental work is okay, but if you had a cochlear implant, stent, or something like that, the magnetic field can interact with that, and we wouldn't want that to happen. So those would be red lights, but for the most part, most people are eligible for this type of procedure. Okay, so we generally, if possible, we would try to offer that to individuals as a non-invasive approach. But for people for whom those non-invasive approaches, medications, CBT have not been effective, what else can we offer them? So as we get deeper in the talk, we're getting more invasive and deeper into the brain. One of the approaches, again, being employed by us is deep brain stimulation, and also talk about focused ultrasound capsulotomy. We do recognize that there is a very nuanced and sometimes complicated history between surgical interventions and psychiatry. I think it speaks to the fact that, as people, we always want to intervene and help our fellow men and women who are suffering from distress. But we do have to tread carefully between these two different principles of first doing no harm, and then to offer a treatment, even if we don't know how it works, and to offer nothing at all. And Dr. Lipsman is a champion of neuroethics, and we always try to thread that needle with these approaches. So a couple of the approaches we're going to talk about first one is deep brain stimulation. This is a standard of care approach in Parkinson's disease. In OCD and depression, it is being used in increasing frequency, but it involves a implantation of electrodes into the brain under MRI guidance. And it's connected to a pacemaker, which is below your collarbone. This stimulation is on all the time, like a cardiac pacemaker. There's no seizure that's being generated by this. And when they come to see their psychiatrist, if they're not feeling well, we can adjust their settings, increase, as we see here, increase their voltage, the frequency, or their pulse width. If you've seen your cardiologist, same sort of principle will apply. What we know from DBS, from our work previously with depression, is that over time, the biological effect increases. So for example, at 3 months, when we put the electrode in this part of the brain, you see there's inhibition actually the deep brain stimulation inhibits the brain at that point. We're not sure exactly why, whether it causes depletion of some of the vesicles, the brain transmitters, or kind of by setting that frequency, it blocks activity that comes out. But functionally, what it does is it decreases the activity, and with greater duration, you have more inhibition there. So this is a theme I want to follow up on with you, that longer stimulation and the effects of these treatments are increasing biologically over time. And we published this study about 5 years ago, looking at individuals with difficult to treat OCD, where we did DBS. What you see here is further proof of that principle, that within 3 months, there was significant improvement, and then it was durable, and it further increased at a year. So there's something about intervening directly in the brain that can lead to durable and accruing results over time. But DBS isn't for everyone. There are some limitations to it. There's the scars that go along with that. There's the need to replace the battery when it is depleted, which may be about every year or so. And so there's a need for other approaches. So one that is really being looked at here at Sunnybrook is the focused ultrasound capsulotomy. And we're thankful to be identified as one of the centers of excellence here. What we know about focused ultrasound is it's an incisionless neurosurgery. So there's no cuts associated with this. But what it does is it takes thousands of ultrasound beams, which can go through the scalp and skull, and where they converge, that energy can be synergistic. So if you've ever, as a kid, played with magnifying glasses and kind of directed them where they focused, you can see the energy increases. So with this, we're able to create a small lesion in real time for therapeutic effects. And we've just published this paper recently, which looked at our experience here up to 2+ years, individuals who've had focused ultrasound at Sunnybrook. And what we found is, again, that principle that more time, the effects continue to accrue and are durable. So this is a group of people who the average age was 41 and were unwell for about 22 years, so more than half their life. These are people who had expert care, with Dr. Richter and others, and we're looking for some options. So what we saw here is that the reduction at 6 months was about 19%, but by 2 years, it was up to 47% reduction in the Y-box score. What this translates to is basically OCD severity and duration over 8 hours a day, down to about 1 to 2 hours. That's what a 50% reduction is on this questionnaire. And you can see the response rates again go up over time. So to quickly wrap up, and then turn it over to Rima, is that neuromodulation approaches are part of the treatment pathway. We don't feel that they are the last resort. We think of them as a cost-benefit analysis. We want to look at what is the cost of continuing on being unwell, or the cost of the cost of the person of being on medications and the health if they're not getting better. And if we're looking at a circuitry-based approach, Many people present with multiple comorbidities. Can those factors be managed if we're trying to intervene as a single circuit to help OCD? So as an example of a stepped care pathway, again, we think of these approaches as complementary. So we would always insist that people have had adequate psychotherapy and medications before moving on to these different steps. But as you go from left to right, you become more invasive in the brain. So with that, I just want to quickly conclude that what we've learned is that the brain is very responsive to external energy, and that can be used therapeutically in OCD. We have multiple interventions, each that work slightly differently and can be complementary. And TMS may have a quicker onset, but the surgical approaches have delayed but sustained effects lasting years. And ultrasound has demonstrated promise as an incisionless neurosurgery for difficult to treat OCD. So with that, I want to thank everyone for coming. Thank Dr. Richter, the Thompson Center, and the members of the Hartwell Center. Okay, we have to go.
Terrific. Thanks so much, Dr. Jacoby. For our final speaker, it's really my honor to introduce them. Rima Youssef is here. Rima is a child and youth care practitioner who previously received treatment at the Frederick Thompson Center. She was a client of the intensive OCD treatment program. Again, a national resource, a one-of-a-kind center in Canada. She also underwent neuromodulation at the Hartwell Center. So we're so very grateful, Rima. Thank you so much for sharing your story of your journey with OCD, your experience from the other side as a patient, and very much reminding us why we're all here today and why we're doing what we're doing. So thank you, Rima, and hand it over to you.
Sorry. Thanks everyone for having me here tonight and for the opportunity to share with you my lived experience with OCD and the treatment of it. I was just 6 years old the first time I began to experience what I now know as intrusive thoughts and anxiety. Between the ages of 8 to 10, I worked with a psychologist who did cognitive behavioral therapy with me, but there were always thoughts that I couldn't work up the courage to share with her, or thoughts that didn't make sense to me, and that I was sure if I had told anyone else or even mentioned, I would be sent away or seen as the worst person in the world. So I said nothing instead. By the age of 12, I was diagnosed with obsessive compulsive disorder, OCD, the 3 letters that I thought would define the rest of my life. The intrusive thoughts at this point had only grown stronger, and then one day my brain came up with a solution. In order to stop the intrusive thoughts, I would start doing or avoiding small little things to make myself feel better. For example, if I was gifted a piece of clothing from my loved ones and it had a tag on it, I would keep that tag so that nothing bad would happen. I wouldn't touch anything that didn't belong to me, because if I didn't touch it, then it was okay if I went the rest of my life without ever seeing it, and that nothing bad would happen to me if I did these things. At night, I would play out endless scenarios and outcomes of different events in my head and the possible situations or outcomes until I tired myself out. This worked for a while, but eventually those things that I thought were protecting me and helping me to feel safe quickly became compulsions. And when OCD doesn't get its way, just like a child being told no, it throws a tantrum. OCD got in the way of me being able to go to school, to play outside, and to even leave the house. I couldn't go anywhere without needing to pick up anything that I touched or grazed or even looked at. And I felt that I had to collect literal garbage in hopes of staying safe. It was then that I went through my first course of exposure response therapy and cognitive behavioral therapy that was directly targeted at OCD and medication. And it worked. I was cured. I had conquered the vicious OCD beast, and as my father proudly knighted me, a fighter, my mom was not as impressed by what I would later try to get away with using this analogy, but she definitely felt more at ease. I later went on to graduate college. I began my first job as a child and youth counselor in my second year of school and got a dog and eventually started university. things I at one point had only dreamed about. Things were going well. I struggled with other things, as we all do, but OCD was kind of a thing of the past. In mid-2018, we were coming back from a family trip to Montreal. Leading up to the trip, my anxiety had been shaky, but it wasn't really that uncommon. We kind of all have bad days, and I was working full-time hours and going to school, and trying to convince my dog that he didn't need to keep dragging my clothes on the floor. Just as we all got into the car ready to go, I had this all familiar feeling in my chest and stomach. The entire ride back to Toronto, my thoughts spun. And sorry, when we were loading the car, my relative had touched my luggage handle after touching their nose. And all I could think about after that was how I then touched that very same luggage and then touched my phone, my clothes, and my hair, and that everything could possibly have mucus on it. But I couldn't see any actual mucus. But the what ifs and the feelings of disgust sent me into a spiral. It took over, and I knew for certain that the bottom inside of my luggage potentially had mucus, but couldn't keep up with exactly where and what touched what belongings. Once I was home, I grabbed every single cleaning product we owned, some old rags, and sat on my bedroom floor and began disinfecting everything. At the time, I didn't realize how many hours I would go on to spend on that bedroom floor over the next year, how many hours I would go to spend to get rid of invisible germs on my stuff or on myself. I mean, overall, I was doing well, and I had a job in the field that I loved, and my family was doing well. I continued to go to school and to work, but the anxiety following up from that kind of moment had just kept building. The fear of touching things that may have been possibly touched by other people or someone in contact with mucus, even if it was a possibility, was just too difficult to handle. I couldn't guarantee who did or did not touch things, no matter how many times I tried to rethink and think over. There was just no certainty that I could come up with. I eventually decided to try psychotherapy, but something just kind of wasn't right. I had a feeling or kind of knew that something about this situation felt very OCD-ish. After some more research and brainstorming, I decided to try cognitive behavioral therapy again. So every week I would go to regular psychotherapy, and every 2 weeks I would go to cognitive behavioral therapy again, trying to work on the OCD symptoms. By 2019, I had to take a leave of absence from work and school. My relationships with my family became strained. I moved into what was my parents' storage room in the basement and found myself confined to that bedroom for about 18 months. I spent those, or I spent countless hours on that bedroom floor disinfecting things and eventually using the same disinfectants that I used for stuff on my face. OCD had taken over, and just as it does, it holds on to the things most important to you. I barely tolerated even briefly being in the same room as my family for the fear of potential triggers. I couldn't hug or kiss my parents. I couldn't touch Max, our dog. I could no longer go to work. OCD had robbed me of everything that I had lived for. In July of 2019, I hit a wall. Through the return of my OCD, I had begun searching for various treatments for adults, but often became discouraged by the waitlists and costs associated. I had come across the Thompson Center page on the Sunnybrook website during a 2 a.m. deep dive research session. It was there that I learned about the intensive OCD program, and I then went on to read every article and hyperlink associated. I even watched a video of Dr. Richter speaking about OCD in the program, the only one of its kind in all of Canada. From there, I knighted Dr. Richter as the queen of all things relating to treating OCD. And as you can imagine, I spent hours researching. It felt like the Thompson Center in Sunnybrook was like this magical place of a fairy tale with the keys to treatment, almost like a Disneyland for the mentally ill or folks struggling with mental health. Sorry. That night, I fell asleep really quickly, similar to how kids do when they've had a bunch of sugar. I had a game plan. I would sign up for this program and do the treatment, and OCD would finally be gone. Only similarly to fairy tales, there was an obstacle. I didn't have access to a doctor to fill out the referral. I no longer had a psychiatrist, and my therapist was unable to sign the forms. My GP didn't have much experience or familiarity with OCD, so that was a no-go. I was crushed. What felt like a dream 1 minute had become a nightmare, and I lost hope. I was exhausted of fighting with OCD and fighting with a broken mental health care system and being tired of doors kind of closing. I didn't know what to do or why this was even happening, and I reached a really dark place. I quit therapy and I had given up trying. I lost hope that there was going to be something I could do. That year, my life changed. In July of 2019, I was hospitalized and insisted that if I needed to go to emergency, then I was only going to be going to Sunnybrook. I was triaged by the nursing staff and then waited to be seen, as you typically do. What I didn't anticipate that day was that I would meet a doctor who would go on to have such a significant impact on my life. I had lost all hope in my abilities to fight back against OCD and felt defeated at trying to navigate the mental health care system. What I, to this day, can't seem to completely understand is how strangers can turn into some of the most influential people in your life. I had never met this doctor before. She was a stranger. And truthfully, she wasn't obligated to show me the love, kindness, empathy, and support that she did that day, and for many, many more years to follow. But what I do know is that she did, and and that I'll be forever grateful to her and her #1 fan. She looked directly at me and said that she would hold the hope that I had lost for myself. With tears running down my face, I had felt steady for the first time. I felt that she heard and saw the barriers that were getting in the way and helped me to break down whatever doors I needed to in order to get support. To regain my life. She saved me that day, and for that, I will be forever grateful to Dr. Rosalie Steinberg. From that day in Emerge, I would go on to have what I call the dream team. So fast forward a few months, I began the intensive day treatment program at the Thompson Center. It felt like my dreams were coming true. I didn't anticipate I think when they say intense, they really mean intense. It was a privilege to be there, and what seemed like it was going to be unrealistic 3 months prior had now been coming to fruition. One of the quotes that we used to use to direct our exposures, to guide them, was that if it feels good, then it's bad. And if it feels bad, then that's great. That was written on the board as soon as you walked into the classroom. I initially was a little skeptical. I knew it said intense, but yeah. Fast forward to my first day, we were going on a field trip. Oh, cool. Okay. We were going to downtown Toronto, and initially I was terrified. I immediately wanted to get in a cab and Uber it back home and never return. But I knew that I had a point to prove to OCD and that I couldn't let it take control over my opportunity for help. Later that same week, I was sitting in the classroom waiting for one of our sessions to begin, and there it was, my ultimate trigger. I frantically paced the hallways, walking back and forth. My eyebrows were furrowed, and I was muttering under my breath. Eventually, I knocked on one of the clinicians' doors, Nathania, and demanded that I needed to go home, or that I couldn't possibly put up with this anxiety without a PRN. Despite having been in the middle of her own work, she opened the door and welcomed me in. I sat on her chair after many redirections and sitting with the anxiety, and began to rant about the disgust that I felt and that I wasn't cut out after all to be in this program. She handed me a tiny bottle of orange essential oil and began to walk me through a DBT exercise. I thought she was joking. I had thought that she possibly lost her mind, thinking that this tiny essential oil bottle and this exercise is going to help what thoughts and anxiety had taken everything away from me. It didn't seem like these conversations or these cognitive behavioral techniques were going to help change things that day. Fast forward to my last week in the program, I was thriving. ERPs no longer really piqued my SUDs, which are subjective units of distress, so kind of like the ladder of stress that exposures give you. They no longer peaked maybe past 30, I think 40 at times, depending. And now I was worried about losing my mind because I was considering doing exposures that I initially thought were really bizarre. But then I remembered how badly I had wanted this treatment and the Disneyland idea of what the Thompson Center and Sunnybrook were and all that the program offered. I remembered the hold that OCD had on me and how if I wanted things to be different, that I needed to do whatever it took to get to that place. I had a point to prove to OCD and that it was no longer in charge and that I was in the driver's seat. After completing the program, I went on to slowly return to school and I could hug my family again. I could attend family dinners, sit on the couch, go to the grocery store, things that typically we would take advantage in our lives. The world was a new place. I was making strides and life was going well. I began a new position at work and I was happy. Fast forward to whenever it was that COVID-19 began. And similar to most people, I was worried about myself, my family, people I cared about. I worried about the impact that the pandemic would have on my newly found recovery, but I felt sturdy. After a year or so into the pandemic, I began to realize that something was wrong. My thoughts had become sticky again, and I found myself reviewing conversations or events from the day over and over again. I became terrified that if I didn't check the schedule multiple times, that I'd leave or return at the incorrect time, which subsequently would lead to me getting fired, people seeing me as incompetent, and never being able to be hired ever again. This turned to checking many different items, and typically until it just felt right, which I never really knew what that meant. Not long after, my obsessions and compulsions around the feeling of disgust and invisible germs returned. How could I be sure that my hands were clean? I washed them thoroughly, but how do I know what's technically long enough or how much soap you're supposed to use? I know what the FDA or what Health Canada tells you is the appropriate amount, but OCD doesn't go by the same standards of logic. If I truly loved my family and valued their safety, I wouldn't touch any of the food that they ate. Only what looking back now, I realize is that with OCD, it's never enough. So there was never going to be clean enough, right enough, straight enough, or enough anything. I was devastated. I had what felt like it wasn't long ago completed this intense program. I took my medications every day. I went to therapy every week. I attended any follow-up appointments, but in life, I've learned we don't get certainty. And OCD doesn't like that. And things were different now. I had a support team and I had a better idea of what to do. And so I re-enrolled in the intensive day program again. It was done virtually because of COVID and I found some relief. Only this time around, my OCD was different. And as my mom likes to graciously remind me that I am a stubborn person, and as my dad proudly reminds her, I am a fighter, I began to apply the skills of CBT and ERP the way I would have in the program. I scheduled regular exposures for myself and would monitor my SUDs. Sometimes it worked, but I couldn't keep up with all the obsessions and compulsions I had developed. At the time, there were various new and different obsessions and compulsions. There were days when I would wake up and a new compulsion suddenly was there that wasn't there the night before. Since having been diagnosed with OCD and up until this point, I had tried around 10 different medications, different classes, doses, and combinations, most of which truthfully were in those previous 3 years. I had completed various years of CBT, and I had been trying other kinds of therapies as well. I had completed the OCD day program twice. It felt as though there was truly nothing left to try. Medications and the gold standard cognitive behavioral ERP didn't work. It just didn't seem to be enough. Treatment-resistant OCD. I spent many long hours researching what that meant and what the outcomes would look like for my life based on studies. If my OCD was so intense that these medications and treatments and that all these brilliant scientists and doctors have spent years working on, what else was I supposed to try? I then went back to the Sunnybrook website and did another deep dive. I found neuromodulation on the website. I found deep brain stimulation and the focused ultrasound. I researched and looked at both a bunch of different times. Not really, it kind of was, it didn't matter what it was or what it was called. I just knew that I needed to do something. So I booked a consult. I had the focused ultrasound surgery in 2022, I believe. And since that day, my life has been different. My brain is different, and I find peace or security in knowing that OCD can't take over and take the same hold over me that it once had. I began to work with Lorraine Fairbloom, who is also part of the stream team that I talk about. And approximately 2 years after surgery, I was able to return to work full time. I recently started a new role in March, and I'm continuing to make strides in my life. I know that OCD will peak, and I know that there are going to be days where I may have a slip, but it doesn't mean that it's a relapse. And I know that my brain is different in that I am fortunate and forever grateful to have the supports that I have at Sunnybrook. I know that that's not as easy or simple for other people who are either currently going through that themselves now, or for parents and loved ones of people who are going through OCD. I think the thing that I always go back to is holding that hope, that even when it seems like every single door is closing in your way and that you're alone carrying these things, there are people out there. You just kind of have to find what your dream team looks like. And I think being truthful about what it is that's happening, because I think OCD isolates us and it makes us feel that we're the worst person or that we're dirty or we can't be around people, but holding on to the idea that there are people out there who care, and there are some pretty brilliant minds here at Sunnybrook. Thanks for having me here. Sorry.
Thanks very much, Arima. That's a fantastic story and experience, and we're so proud of everything you've done and for articulating your journey. Thank you very much. This concludes our presentations, and we'll finish it off. I'll ask all the speakers to please join us on the stage for the last 10 or 15 minutes here. We have some questions from the audience that I've collected here. If you have any additional questions, we're walking around with a basket. So once our panelists sit, I'll ask some of the questions that have come up, and whoever wants can just grab a microphone and just answer them. The first question, maybe actually I'll direct to Peggy first, if you don't mind. The question is, how do you access the Thompson Center as an adult? Well, what's the process? How do you get into an OCD program as an adult patient?
How to access
Yeah.
our center.
Yeah.
So there actually is a sheet, I think, outside that we put up to help people with navigating, but really if you have reasonably severe OCD that has failed one or more treatment, anywhere in the province, then all you need is a doctor's signed referral form, and we will meet with you for at least a consultation, and then beyond that, it depends on what kind of treatment is needed. So,
Perfect, thank you. Another question, youth under the age of 18 don't have many options for publicly funded OCD intensive treatment. What plans are there currently for the Thompson Center to treat youth?
tough one. What I will say is that right now, we do not have immediate plans to expand our program to youth. But there is recognition on the part of the Ontario government that services for youth are needed, and people with severe OCD who are below 18 can access care out of the country. I know that that's not maybe the most wonderful answer people would like to hear, but the government will cover that kind of treatment if indicated, supported by your physician, and looks like the best shot at recovery for a youth person, for a youth or child.
Thank you. Maybe Dr. Vinci had a question for you. Do you find that OCD is on the rise? Is it becoming more common? And what are some indicators if so?
It's a really good question. It's hard to say, is it on the rise or are we recognizing it more? And is there more information out there? You know, we've throughout all of these different talks, you've sort of heard these themes of how people think OCD presents and then the myriad of ways that it actually can present. And so on the rise, maybe in terms of being aware of it, one thing that I'll say that I think is on the rise, and you know, fall is different presentations of OCD that can sort of like rise and fall with what's in the news, what's in popular media. Related to my talk, I think a lot of us have seen an increase in gender identity obsessions, for example. So I don't know that I would say necessarily OCD itself is on the rise, but I think we're getting better at identifying and treating.
Great. We've heard a little bit about core fears, and there was a question from the audience. What are some examples of core fears?
That's a great question, and thank you for asking that. So a core fear would be kind of a deep-seated fear that someone typically has about themselves. So it might be, you know, I'm dangerous. I'm a bad person. It could be something like I'm gonna end up alone. And these sort of span across different OCD themes. So this theme of I'm a bad person, someone might have that core fear if they have, you know, harm intrusive thoughts, and those thoughts they feel sort of like prove that core fear correctly. But you might also feel that you or have a core fear that you're a bad person if you have some other taboo themes as well. So those tend to be the big ones, is sort of fears that someone has about themselves that they're afraid might be true.
Great, thank you. Peggy, maybe you can answer a question about impulse control disorders. What is the state of the art for trying to treat impulse control disorders, specifically severe picking behavior? And then two-part question, Peter, for you. What are some of the side effects you've seen with focused ultrasound? So maybe Peggy first up.
So if we're talking about things like skin picking and hair pulling, they have at times been considered impulse control disorders, but now we tend to conceptualize them as part of the OCD spectrum. So we call them OCD related disorders because they bear so many similarities. So just to be very specific, we're talking about people with what used to be called trichotillomania or hair pulling disorder, and skin picking disorder, which was referenced in the question, conditions which people really have difficult to resist urges to pull or to pick to the point that they cause damage typically, or certainly painful awareness of loss of hair or discomfort from the picking. There's also things like hoarding disorder in this category and body dysmorphic disorder. And the question was treatment. So treatment it's a really good question because many people out there assume treatment is the same as it is for OCD. It's similar, but there are big differences. So CBT is used, but just like with OCD needing a very specific approach to work for OCD, we have specific approaches to CBT that work really well for these conditions. Generic CBT, the kind that is used by a lot of practitioners very effectively for depression or anxiety do not. And the medications overlap with OCD medications, but there are differences. So that's probably another whole topic, but just be aware of that.
So part two was the side effects of focused ultrasound. So part of the study that we did was really focused on the safety of this procedure, looking at things from a brain health point of view, cognitive point of view, side effects, et cetera. And what we found was there were remarkably no serious adverse events. So serious adverse events would be events that require treatment of in themselves, required hospitalization, and there were none, actually. So it was very well tolerated from that point of view. We also had a team of psychologists look at cognitive function, and there was no worsening in cognitive function. In fact, apathy improved, which part of the historical shadow of lobotomies and surgery was that it would affect cognition and different aspects of people's personality, but that wasn't seen. What we did see, actually, what I've noticed in the clinic is that sometimes afterwards people have a headache. The heat that's sometimes can cause a bit of headache. The halo that's put in also can lead to some headache, but mostly transient and remarkably well tolerated procedure. Dr. Lipson and I often talk about this, but it's we call it maximally invasive psychiatry. It's the most invasive thing we do, but for neurosurgery, it's very minimally invasive. So it's it's two sides of the same coin there.
Exactly. Okay, a couple of questions about TMS, Peter, if you don't mind. What are the approved indications for our TMS? And does a person have to be off of their medication to access it?
Yeah, so the official approved indications are for depression that has not responded to one treatment, OCD, and nicotine dependence. That being said, we have treated people with bipolar disorder who are in a depressed state. We've treated people with PTSD who also have depression. The main contraindication would be individuals with psychotic illnesses. That is not responsive to TMS, so we bypass that step. And sorry, the second part.
How long did the effect last?
Oh, sorry, there's also medications.
Yeah, do they have to be off of medications?
Don't have to be off medications. From our data, approximately 80% of people were on medications, but about 20% were not. And those people had the same benefits. So maybe there's a 2% superiority if you were on medications. So what we tell people is that if you can tolerate a medication, stay on it. You may get a little bit more out of the TMS. But if you are not on a medication, you don't have to start one. It seems to work independently. It doesn't require medication. How long do the effects last? So in some of the work we've done, it can last for several months. So what we do is we do the acute course, which lasts 4 to 6 weeks. And then afterwards, we follow people at 1 month, 2 months, 3 months. People are typically doing better at 3 months than when they stopped. But sometimes people will need boosters. We continue to follow them. Instead of coming daily for a treatment, they might come in once a month just to top it up. We want to be proactive and get people treated before they feel unwell again. And so we can target with individual treatments every few weeks, every few months. That can keep most people well. If people have a relapse, we can offer them either a new course of treatment again if they've responded, or if they haven't responded fully, then we would offer the other options further on in that care pathway, including maybe focused ultrasound.
Thank you. Couple more questions. Have there been any studies done on OCD therapy and the use of cannabis? Maybe I'll ask you, Peggy, first, and Dr. Panciotti.
Yeah, cannabis is a big question, isn't it, for everything these days? And the sad reality is that there's really very little research. There are no studies, none, of OCD and cannabis. Even with regard to anxiety, they're very limited. They're not really treatment studies that are specific to any of the anxiety disorders, but rather generally, for example, asking people after exposure to cannabis, how was your level of anxiety? And so what we have is kind of a mixed bag there, in that cannabis acutely for most people does have some anti-anxiety effect, but with regular or longer term use, the actual available data suggests many people feel worse. So that's the anxiety world, and in OCD, we just don't know.
A question for you, Rima. If you can go back in time, what message would you give yourself from 5 years ago? If you could speak to yourself from back then.
I think the big thing was realizing how resilient I am, or that we are as humans. And I think when we hit a place and when OCD is really bad, we convince ourselves that there is nothing that's more powerful and that we cannot relinquish control back over ourselves and then our autonomy to do things differently. I don't know. I think part of me thinks that it was a very strong lesson, and it's now connected me to so many different people who continuously are so supportive and who put me in my place when I need it, but also give me a shoulder to cry on. And I think it's also living with or struggling with mental health or anxiety, at least working as a CYC, gives you a different perspective into what your young folks are experiencing and what life is like for them. I think it comes down to resilience and making something out of the experiences that were really shitty.
That's okay. That's okay. I think that one of the themes that I came across in the last 2 hours is really of hope. Whether it's new treatments, better understanding, and enhanced sort of approaches to OCD across the spectrum. So on that note, final question for all the panelists. If you can give us sort of your hopes for the future of OCD, maybe for the next 5 to 10 years. What are your biggest hopes for the field? We'll start with Peggy, Dr. Richter.
Well, that's a tough one. I have so many. But I mean, my gestalt hope is, wouldn't it be wonderful if we have personalized treatment where we knew in advance what people need and everybody could get access to it. Of course, that's kind of a dream. I think a more realistic hope is that we really are looking towards expanding our intensive program, making it more available. And that's something we're working towards very seriously. And we really look forward to doing more mobile with the Heart Valve Center and expanding availability of neuromodulation. So those are a couple of them.
I would say my hope would be that we continue to really study how to make ERP as effective as it possibly can be for all people. I think that we have a treatment for OCD, a CBT treatment that's really effective and really great, and that's not always the case for mental health concerns. And I think that there are ways that we can continue to tweak things and improve things so that we can reach more people. So that would be my hope.
So my hope is that we can take what we've learned and really, move the needle across the country. And basically, I think for us to do that, we have to increase the accessibility of these treatments. We have to get the government to pay for TMS and for focused ultrasound. We have to educate people, including practitioners, about these techniques. Even if you're not going to be somebody who's doing these techniques, to recognize when people might respond to them. And so we're playing that long game and training people from medical school all the way to fellows to spread the word about this. But I think it's really about accessibility, kind of taking what we've learned here and not making it just a Sunnybrook specific thing to be something that's available across the country.
I think it's similar to what Dr. Jacoby said. Accessibility is a really large aspect of treatment for OCD. There isn't, or I guess depending on your financial situations, accessing cognitive behavioral therapy or ERP in the community can be very expensive with clinicians who are specialized in that. I also think the Ontario government does need to step up in terms of the funding around neuromodulation. But I also think, or my last point would be, erasing the stigmas around OCD across the board. So not just for the typical things we see in movies around washing and checking, but around some of those more intense taboo OCD thoughts or symptoms that people go on and suffer in silence with.
Thank you. Thank you to the panelists and the speakers. So we've come to the end. We've come to the end of the Q&A and the evening. Just a few more points before we wrap up. For those of you here in person, if you haven't already, please take some time to visit the community organization tables just outside. We'd like to thank all the organizing representatives that have joined us here this evening, and they include Christine Chu from OCD Toronto Support Group, Marilyn Kiefer from Maid of Millions, Anne-Marie McDonald from Hope and Me, QV Mai from the Department of Psychiatry Patient and Family Advisory Council, PFAC, Karen Hencher from the Thompson Center, Patient and Family Advisory Council, Lisa Cooter from the Family Navigation Project, and Joe Modeste from the Obsessive Compulsive Anonymous Group. So earlier this evening at the welcome table, we handed out OCD Awareness Scavenger Hunt slips. Those who complete these and return them to the welcome table will be entered into a prize draw for the $50 grocery gift card. So please do that. If you have not had time to do this, please visit our tables just outside. They'll be open for another 10 minutes or so. And for everyone joining us this evening, if you'd like to stay in touch and informed about future events like this one, please visit the Thompson Center website at sunnybrook.ca/Thompson Center. You can sign up there for a mailing list to receive notifications right into your inbox, so please do that. You'll also receive quarterly newsletters, which you can view at the table just outside. So I want to thank again all the organizers, all the speakers once again for an exceptional evening. We learned a great deal, and I think leaving with a lot of hope about the field. So thank you again for joining us, and have a wonderful evening.